Welcome. You're listening to the Leading Health Podcast by the Kansas Health Foundation. We have a bold vision to make Kansas the healthiest state in the nation. And it's not just a vision, it's a movement powered by people like you. You are one of the 30,000 Kansans invited to help us shift our state's future. We're your hosts, Ed O'Malley and Susan Kang.
In each episode, we move beyond the usual conversation about health, the doctors and deductibles. Instead, we talk about capital H health, our ability to thrive. This is your invitation to grab the Leading Health book and join the conversation as we work together to make Kansas the healthiest state in the nation.
Welcome back to another episode of Leading Health, the podcast that dives into the book, Leading Health, How You and 30,000 Kansans Help Communities Thrive. So, Susan, here's where we've been. The last few episodes, we started with talking about capital H health versus lower H health and the difference between the two, and that this book is about capital H health. We then described the 30,000, who they are, what role we need them to play if we're going to help Kansas thrive. And we juxtaposed those 30,000 to Alice, that population of the working poor whose health outcomes have suffered, whose population size has grown over the last 20 years in Kansas. And we also described the health ranking as an incredibly valuable North Star. It's a rallying point, and the book makes that clear. Now, today, we're going to dive into what's life like when Kansas is ranked in the bottom half. What's life like when Kansas is ranked number 29 in the ranking like it was when this book was published? And of course, we're doing all this so we can fan the flames of a conversation about health in Kansas, a conversation, frankly, that we need the 30,000. Those are Kansans with roles of authority throughout civic life, elected officials, pastors, rabbis, university presidents, school superintendents, community-minded business people. We need a conversation among them about the critical nature of improving health. And that's what we're trying to do with this podcast. It's great to be back with you.
It's so good to be here. Okay, I am so excited about diving into chapter 4, right? That's what we're talking about today. We've talked about, and Ed already referred to this, so we have this goal to lead the nation in health, right? Which is absolutely awesome. But first, we need to take an honest look at where we are in Kansas today. So when the book was written, we were 29th. Today, as we sit on the rankings, we're 27th in the nation. All right, so yay for the incremental progress that we're making.
A little bit of progress.
We did, a little bit, but we want to make more, right?
A lot more.
Okay. So this chapter, as we dive into it, it's about how this chapter challenges us to start thinking collectively and take some responsibility for moving forward from good enough to true excellence. So super excited about this. Ed, would you just go over some of the key concepts that you think would be really helpful for us to know?
Yeah, this is the chapter where I feel like I run the risk of everybody thinking that I'm a glass half empty person. And I'm not.
No
I know,
way.
It's not
no
true.
Way.
I'm a very positive, optimistic person.
Yes.
But I've also learned throughout my career, throughout my life, that leadership always, every single time, starts with dissatisfaction. Mm-hmm. You know, it starts with somebody on a football team craving more victories next year than this year. Somebody in a theater troupe craving better reviews, a better attendance next season than this past theater season. Leadership is always about dissatisfaction, and that's what this chapter is trying to do. It's titled, Kansas at 29th, and it starts off with a lot of depressing data.
Yeah.
And we won't go through that here, but folks can go to the book and check out chapter 4, see that data that we're pulling from America's health rankings and some other sources too, to paint a picture for what life is like in Kansas when we're in the bottom half of the states from a health standpoint. And the reason why this chapter is so important, and especially so important for the 30,000, is because as we explored in a previous episode, the health of the 30,000, the health of people with a lot of opportunity, with a lot of authority, frankly, their health is as good or better than it's ever been. Right. So what we're really talking about is as we have fallen the last 35 years in the health rankings, it's the health of people across the state the Alice population and beyond that is suffering. This chapter tries to hit that home, but it's really a chapter about how leadership requires us to face the music, to face hard, tough things, and not just sweep those under the rug.
Right. So you talk about an easy interpretation versus a tough. So I want to emphasize this. It's not a tough interpretation. It is a tougher interpretation, right? As between the two. So say a little bit about that.
Well, I think I've noticed over the last 25 years as we have slid in those rankings. And I've been around. I've been involved in civic life for 25 years in Kansas in lots of different ways. And what I've noticed is when the rankings were come out, first of all, they often wouldn't get talked about because who wants to talk about bad news?
Right.
Well, I think people who are trying to create change often need to talk about bad news, but it often wouldn't get talked about very much. When it would get talked about, my sense is it would be explained away. Mm-hmm. It would be, well, yeah, but the ranking, they you can't trust rankings. Who knows who's actually behind that thing anyway? And I think the easy interpretation was to assume that, no, we're actually doing fine. There's something wrong with the ranking. Mm-hmm. A tougher interpretation is, what if the ranking's accurate? Mm-hmm. What if it's actually a really good proxy?
Right, a little scarier.
Yeah, now it's a little scarier. Mm-hmm. What if a tougher interpretation is, wow, really during the time the Kansas Health Foundation has been in existence, we've been falling in the rankings until the last few years. And we've, for the first time, we're very proud of this, as you know, Susan, for the first time in 35 years, Kansas for 3 consecutive years has improved in the ranking. We went from 31st to 29th, 29th to 28th, 28th to 27th. Now, we're not satisfied, and we have a long way to go. But the easy interpretation is to assume this ranking isn't relevant. It doesn't really concern us. We're doing great, but we have to explore tougher interpretations, which is what this chapter is all about.
Tell us a few more, give us a few more examples to help us see the difference between the easy and tougher interpretations.
Yeah, Susan, again, this is such a key concept, right? Those who exercise leadership, they know that they can't just always assume the easy answer or the comfortable answer is the answer.
Right.
Or the comfortable way of explaining the situation to themselves is the correct one. So, for example, I hear a lot of times, well, hey, our health is going down the drain. Our health ranking is falling low. It's got to be these lazy people who aren't taking care of themselves, who aren't exercising, who aren't eating well, okay, that's a very comfortable interpretation. Mm-hmm. It's saying it's not my fault. It's somebody else's fault. Mm-hmm. Now, I don't want to say that there might not be personal responsibility in this equation, but what we've said often throughout this book is, if we can make sure there's a level playing field for everybody, then somebody's poor health is on their back. But if the playing field's not level, then let's assume there's some collective responsibility too. Or another easy interpretation is, well, this is all just a big national thing. Like Kansas is in the flow of a national river. When it comes to health, capital H health, what can we really do in little old Kansas? We're pretty tiny compared to the bigger system or the bigger nation. And I just refuse to believe we lack agency. I refuse to believe that we are just along for the ride. But so this idea, if we don't get people to question the easy story, it's really hard to mobilize the difficult, frankly, provocative work that's needed. And we'll talk about that provocative work later on in this podcast series. Okay. Yep. But we've got to land this idea first.
I love the notion of us, Kansans, having agency, right?
Yeah, well,
especially over our health, capital H health. So I think, all right, I'm gonna hold that. May I ask you to talk a little bit? There's another concept that I want our listeners to know about, which is this notion of our biggest challenges requiring both adaptive and collective work together, right? Leadership. So say more about that.
Yeah, this idea came from a lot of deep listening we did in 2022, latter half of 2022 and 2023, when we were trying to reground ourselves in the voices of Kansans. We're doing a lot of listening. And when I started the Kansas Leadership Center, I did a similar process with the team that started the Kansas Leadership Center, where we asked big open-ended questions to Kansans to try to get our arms around what's happening in the state. and wanting to use that listening to inform our thinking and eventually our strategies. And on one hand, I heard a lot of things I've heard before. The team that did that listening, we heard a lot of things we'd heard before, which is okay. That's fine. So it's confirming some things had stayed the same. Things like we need more and more people who understand how to mobilize others, to understand how to exercise leadership. Like just being passionate isn't enough.
Right.
So some of those things we heard again. One of the things we heard that was new is this idea that the challenges aren't just adaptive. So that refers to, adaptive challenges, wicked problems, vexing challenges, lots of different ways.
Technical stuff.
Yeah, versus technical stuff, right? So the language that I've always used is, adaptive challenges versus technical problems. Well, for years, we've been hearing that the toughest challenges are adaptive, meaning they're messy, there's no easy solution, so on and so forth.
Yeah.
Now, what we heard that was new, that you're bringing up, and that we write about in this chapter, is that the 2020s, the challenges are adaptive and collective. So the key difference there is they're still adaptive, they're still vexing, they still resist easy answers, there's still no way to make progress without evolving, adapting, which means like taking on some loss, like letting go of some things. But also they're collective, meaning like nobody can do this by themselves. No one Kansan, no one community, no one organization. It takes us working together, frankly, is what Kansans were telling us, in ways we haven't learned how to do yet to make progress. So improving health, capital H health, is adaptive and it's collective. So what we're trying to say in this chapter is, hey, look, we've been falling. And Kansas at 29th, and now we're 27th, but when we wrote the book, we were 29th. Kansas at 29th is no good. And here's what it looks like. And improving that will require us to face the music and to do it together in a collective way.
Yeah. And I love the fact that not only our leadership challenges are adaptive, which we already knew about, but also now collective. And the word collective for me also brings forth the need for collaboration. And I know we're going to cover some of this stuff, I think, in some of the other chapters, but the importance of collaboration when working with more than one group.
Yeah, it's such a, we can hit these points several times because they're hard to absorb. But we will not make progress if we don't begin to get people working together in ways they aren't used to working together. That means like the 30,000, right? So like elected officials working with the private sector on health, capital H health related things. That looks like different levels of government working together in ways they're not accustomed to. Frankly, it looks like different factions with different political ideologies finding common ground in ways that are necessary. And what we're trying to do with this chapter is say, look, we've been dealt a hard hand. We're in the bottom half of states now, but we're not playing the hand well. And we've got to play it better. And the people who get to control how we're playing the hand is the 30,000.
Right. And these are some tools.
These are some
30,000 can use.
So we're going to get into this. And one thing we're excited about is we've got Kari Bruffett from the Kansas Health Institute with us today. And Kari is just one of those people that if you want to talk about health in Kansas, you better have Kari close by. Because
so true.
So true. She leads an amazing organization, the Kansas Health Institute. We're obviously very fond of it. The Kansas Health Foundation has a long history of supporting the Kansas Health Institute. It's one of the foremost entities in the state that can not only dive into and help us understand, us meaning the 30,000 and beyond, an entity that can dive into and help people understand what's currently happening related to health in Kansas, but it's also an entity that looks forward and can help us understand what's to come if we don't evolve the way we think about working together, if we don't evolve the way we think about the relationship between policy, and that can mean lots of different things, corporate policy, organizational policy, governmental policy, the relationship between policy and capital H health. Kari is phenomenal. Let's get Kari up here with us and get this conversation going. Kari, awesome having you with us. You have been so involved in Kansas civic life. You've done so many different things. You worked for the University of Kansas Health System. You were a cabinet secretary. You were the secretary of the Department of Aging and Disability Services. You are now the president and CEO of the Kansas Health Institute. It is awesome having you with us. I love our partnership. Thanks for being a partner with KHF, and thanks for being here today.
Hey, well, thanks for inviting me. I'm looking forward to it.
Welcome, Kari. Super, super excited to have you here. So I'm really glad for this conversation. So one of the concepts that we talk about in this book and Ed highlighted is this notion of multiple interpretations, and especially around tough versus or easy versus tougher interpretations. So I'm curious to know if you can share a situation in your many years of data experience, especially, right, where you've seen data initially dismissed or explained away, but then you took a closer look, right? And that led you to a tougher interpretation.
Yeah. So you guys were talking about America's health rankings and our quest for Kansas to lead the nation in health. The Kansas Health Institute has worked for many years with the county health rankings. So I'm going to give an example. I don't want to confuse the two. They're very different, but it really is very on point to your question about tough interpretation. So I was working at the KU Health System. It was called something different then, KU Hospital, in 2009, so well before I was at the Kansas Health Institute, when KHI produced the first Kansas County Health Rankings before it became a national thing. And Wyandotte County, Kansas City, Kansas, is where KU Hospital is located, came out ranked 105th out of 105. And I remember being at a meeting that the mayor at the time, Mayor Joe Reardon, had called to sort of understand or really dig into those rankings. And there were some in the room, including probably some folks like me from the KU hospitals, like, how could this be? There must be some sort of other explanation, or we can explain it away. We knew there were challenges, economic challenges and infrastructure challenges in Wyandotte County, but seeing the 105 out of 105 was a really stark reminder and a need for urgency. So there was a concerted call for organizations to really work together. But I will tell you, I spent some of the time after that first meeting looking at those rankings and sort of trying to go in and say, well, that can't be, or well, how could a hospital or a health system really control these? Why are these included in the rankings? And really sort of trying to say that, so not to fully discredit them, but say there is something else we can use to explain it. But that wouldn't have gotten us anywhere, just to explain away something. It's like a check engine light on in your car. If it goes on, and you say, oh, I don't really want to pay attention to that check engine light, you can tape over it or ignore it, and probably your car runs for a while, and then eventually you break down if you don't address the issue and get to the bottom of the issue. So, you talked about America's health rankings, and for KHI, one of my colleagues at KHI, Kevin Kovac, inspired by the Leading Health Initiative, really did a study of a lot over the last 18 months or so, working with leaders across Kansas to say, why? Not just, we know that Kansas had experienced the greatest drop in America's health rankings, but why is that? Why? And instead of, again, trying to explain it away, I've heard that sometimes explained away as, oh, well, Kansas is an aging state, so that explains it. It doesn't. All those rankings are age adjusted. So what are the explanations? So what we got to are the result of that project, which was asking more than 100 people that had experience across domains, both in health, public health, business, government, and policy. A lot of folks from public health were the ones who really engaged with it and responded to it, identified policy barriers as being the primary thing. And those are hard. And those aren't just governmental policy barriers, as you talked about, Ed. They can be a lot more. And it's not going to be a technical challenge or a technical fix that corrects or turns around America's health rankings for Kansas. And we have to, when we examine what is actually driving it, we know it's not going to be quick either. It's going to be long and hard and important work. So I think those really getting into maybe some uncomfortable interpretations of policies. Who is responsible for implementing those policies, and how does that impact our ranking overall? That can create some pretty challenging conversations. So we dive into that, and we want to bring other people into the conversation so they can see themselves not just in the problem, but hopefully in the solution.
Kari, I want to play with just a couple things you talked about for a minute. And one of them is, I love that you referenced the story back to 2009.
Yeah.
And I remember some of those conversations. I wasn't living in Wyandotte County, but I was with the Kansas Leadership Center, and I ended up intersecting with some of those conversations in Wyandotte County. And I just really appreciate you bringing that up as a story and as a situation where it would be easy to assume or to tell ourselves a story, tell people in Wyandotte County to tell themselves a story that this can just be explained away. And my recollection is Joe Reardon, who was mayor at the time, really didn't allow that. Really said, no, we're not going to just put this behind us. We're not going to, I loved your metaphor of the check engine light. We're not going to put tape over the check engine light. We're going to focus on it. Can you talk a little more about, because in some ways that's a really good example of a member of the 30,000 trying to rally people to focus on capital H health. So what was that like? How did you experience him doing that?
Yeah. So, and again, I was working at the KU Hospital at the time, but have talked subsequently to some of my colleagues who were at KHI at the time too, and they remember a meeting I wasn't in, but that they were in with the mayor, where he asked some tough questions and really sort of interrogated the rankings and how they should think about the rankings, and then said, okay, what are you going to do to help us fix it? And so one of the things they did was they actually asked KHI and other partners, the Leadership Center and others, to come to Wyandotte County and help engage the full community and leaders in the community, others of the 30,000 who could really dig into what they needed to do to create change in Wyandotte County. And one of the things they really did extra research and diving into are what are those factors, those upstream factors that maybe weren't even yet in the rankings, that they didn't even show up in the rankings, but were behind something that was in the rankings. And so, for example, one of the things they identified were transportation barriers that were real impacts on people's not just access to care, but their ability to get to jobs and, impacting their ability to access other services in the community. So they took community action and created organizations that still exist today that make a big difference in Wyandotte County, changing some of the conditions that impact health in Wyandotte County. So yeah, it was absolutely inspiring. And then the mayor said, hey, KU Hospital folks and other folks, you need to be at the table too. You're a great hospital. How can we also improve the entire health, and not just our health care, but the health, capital H health, of Wyandotte County?
It is a great example. And my recollection is Mayor Reardon did not run on a platform of what we would call capital H health.
Right.
He ran on a platform of all kinds of things, economic development and growing Wyandotte County, all this stuff. But he responded to the data.
Yep.
And he did so in a way that I think is a really beautiful example of what we need from people with authority. He used his authority to convene and to direct attention on something that needed attention. So that's, for the members of the 30,000 who are listening, that's what we're talking about.
Yep.
That's the role. And the mayor can do that in that situation differently than a prominent physician at the hospital system could do it. Different people are going to show up at the table. And that's the point. This is not a problem, a challenge, a situation that can be solved with health care at the tip of the spear. Health care is a part of it, but the tip of the spear has got to be the 30,000 engaging people differently. I just love that you told that story. Thanks for bringing that up.
Yeah, you bet.
That's a great example of a member of the 30,000 truly exercising leadership, right?
Yes.
And trying on tougher interpretations. I think that's really great. And there's another chapter highlight, Ed, that I wanted to talk a little bit about, but I might need you to talk a little bit about that before I ask the question of Kari. And that is this notion of even when we try, even we as Kansans try our best, we end up sort of arriving at average. So that doesn't sound great to me. So first of all, why is that in the book?
Well,
and what should we know about it?
I mean, this is the chapter where I'm embracing the part of me that is a glass half empty, although I am more of a glass half full type of person. But yeah, we put that in the book because I think what we found, and this also came from the listening. I mentioned the listening that we did earlier. One of the other things we heard during that listening was that a lack of bolder aspirations was actually getting in the way. That there's a little bit of aw shucks in Kansas, we're humble and we're kind of attitude, which on one hand is beautiful and full of humility and fantastic, and kind of that Great Plains ethic of we're just going to kind of be out here by ourselves and handle some things and we don't need any attention on us. But what Kansans were saying in essence, in so many words, were, yeah, it's fine. However, when trying to solve a vexing adaptive challenge like the massive decline in the health rankings, a lack of bolder thinking is a problem. And so that led us down this path of thinking that when we do rally, when we do really work on something as Kansans, it's hard to find many examples where we're trying to like rally to get to excellence rather than just like rally to catch up. And I give a couple examples in the book, and one of them is here in the city of Wichita, a meeting I was a part of a couple years ago where I'm on the board of the Greater Wichita Partnership, which is an amazing organization, and we were having an update from the city about the need to evolve our economic development policies in the city. But the whole frame was we have to get our policies caught up with the other cities that are competitive peer cities. It's like we got to catch up. The aspiration is to make sure we don't get left behind. It's not to lead the way. And we know what happens when people decide to lead the way. And Kari, I mean, you were at the University of Kansas hospital system.
Yeah.
That's a hospital. And I write about this in the book. That's a system that was one of the worst in the nation. And when I was working for Governor Graves, the discussion was to shut it down, right? And the story goes that they were given one last chance to kind of let's see if we can make this thing work. And because of incredible leadership from so many people, that is now one of the best hospital systems in America. But they strove not just to survive, they decided we're going to go for excellence.
Yes.
It's an incredible, incredible story. So yeah, part of what we're saying here is we got to rally not to catch up, rally not to get to average, but if we rally to be excellent, it changes the mindset of things. Does that feel right to you, to both of you?
Yeah. And so what I want to know from Kari is, can you share an experience where the goal shifted from just catching up to true excellence? And if so, if you have one of those examples, what I'm also curious to know is what had to change, maybe culturally, maybe structurally,
Right.
in the organization or in the community that helped you make that shift?
Yeah. Ed talked about the KU health system already, and the best example from my early part of my career really was that. It was not a matter of, hey, let's just survive as a hospital. Yeah. It was leadership among the folks, including many folks who are still in leadership in the health system, who said, no, we're going to become the best. We're not just going to get to survive and not be closed down, to your point, Ed, but to actually exceed, to get National Cancer Center, National Cancer Institute designation, for example. That was an important step, and that's not something that was easy to accomplish, and it was something that was important. That isn't just to excel for excel's sake. That is for the good of the people of Kansas. But in order to get that designation, you have to excel. So I think you already took my best example. I will say in my time in state government, both when I was in state agencies or I'd be testifying before the legislature, and even at KHI when we provide comparative data about Kansas and other states, I see that symptom that you talk about, Ed, pretty regularly, which is policymakers and others just want to say, well, where are we below average or maybe trailing our neighbor states? How do we get up there? If we're kind of in that territory, we're probably okay, is sort of the take. And so the focus is on maybe where Kansas is trailing the most, which that's important to fix that. But it isn't often on, well, how can we beat them all?
So that's a bold aspiration, right?
And not for the sake of being competitive and all that, although there's probably some element of that might be appealing to some, but for the best outcomes for Kansans. So I do see that very starkly and very real. And I think that can be a reason why sometimes with America's health rankings, the change for Kansas wasn't overnight. There were a couple years where maybe the dip was a little bit faster, but for the most part, it's sort of gradual. So that check engine light was on pretty early, and all of a sudden, it wasn't until we were well below, not in the middle anymore, but actually below the middle, that it really caught the attention. But we're not trying to get us like, let's get to 25th, and then we'll be happy because we're in the middle.
Right.
So I appreciate that. I think one of the things that, I don't know, I can't speak for culturally within KHF, but within KHI, one of the things that I see is sometimes a limiter to thinking about going to exceed or excel is the idea of being limited by our current systems and the status quo, and feeling like the only things that we can do are sort of adjustments around the edges, modifications, even if they're adaptive changes, that they're still kind of just adjustments. or they're small technical changes that may be really important for certain programs or maybe even some subset of populations, but really aren't going to drive real change. So one of the things we're experimenting with at KHI is this idea of reimagining the healthcare system. We've had a couple of these. We're going to have them across the state too, where we ask people to come with all sorts of backgrounds from the 30,000 and in their communities really across the state to say, if you could design a healthcare system that was the ideal of what we wanted for our healthcare system, and you're not limited by anything, you're just starting from the ground up, what would it look like? And then we'll take from there, create things that can be changes that can be made, that maybe will be some of the incremental things, but we're not bound by, the federal limitation here that maybe we could ask for a waiver around, or, we've always done it this way, so it'd be really hard to get this industry to change their perspective on something. Think big in order to excel. And I do think that's a limiter, and I don't think that's unique to Kansas by any means, but I do think I've seen that as a symptom over time too. It's not just like, let's make sure we're in the middle, but also there's only so much we can really do is sometimes the limiter.
Yeah.
One of the roles of authority is to help people not be bound by what people perceive to be kind of the system constraints.
Right.
So like your practice of asking people to come together to reimagine, that's such a beautiful word, to reimagine the health system. Mm-hmm. And you can imagine other members of the 30,000. So like Kari, you in your role as one of the 30,000, CEO of the Kansas Health Institute, you're using your authority to ask people to imagine something that doesn't have the current constraints. Mm-hmm. And that doesn't mean we can just wipe away all those current constraints, right. But if we can begin to imagine something beyond that, we might be able to be inspired enough to then figure out how to knock some of those constraints down. But we all could picture other members of the 30,000 asking similar questions. How do we reimagine our workplace in this manufacturing plant to optimize capital H health?
Yeah.
What would that look like? Don't be constrained by what is right now. Imagine we were reimagining this manufacturing plant from scratch. Mm-hmm. How would we do it? So there could be lots of versions of the process you just described.
Yeah, absolutely.
And I love that word, reimagine.
Well, and that creates a safe space, I would say, for your employees and other people who work with you, partners, to be aspirational, really creative, and really bold. And I think without that, we never get to the awesome solutions.
Yeah, absolutely.
Yeah, I love that. Thank you. That is an excellent example of a cultural or structural shift. So I have another question for you. This is so great. Ed already covered this whole notion of our biggest challenges being adaptive and collective in nature. But, it's increasingly more difficult, right? And we know that it takes more than more than one organization, more than two organizations to really try to tackle the challenges that Kansas faces. But, polarization across political spectrum, societal and systemic issues, those continue to widen, which makes it hard, I think. So in your experience, what helps groups move from sort of the scarcity mindset? In my mind, that's that's one of the problems. So, having a scarcity mindset, that is to say, fighting for a piece of a limited pie, right? To embracing collective leadership and, around adaptive challenges.
Yeah. So I have an example that Ed's going to be familiar with because he was involved in this as an MC. So Cowley County, this was I think in 2022. So leaders from Legacy, which is a regional community foundation, collaborated with Rise, Cowley, and the school district early literacy program to host something called a data walk. And we can go into detail about what data walks are. We love them. It was the first one we got to participate in. But the idea of a data walk is to bring people together from a lot of different background and experiences, some of the 30,000, maybe some of the 300,000, that are influencing or affected by challenges in their communities. So in this case, the limited resources weren't necessarily dollars. They might have been, but it could have been attention from policymakers or credit for working on an issue. But they brought together large subsection of Cowley County to look at community health data, a lot of focus on early childhood and educational data, but it had broader capital H health data as well, So there's these big posters that show data that sometimes can be challenging, that require multiple interpretations. And instead of those posters telling people, here's what you should take from this, it's asking people, what can you tell us, or what can you tell each other about what you see in this data? Why are there challenges for literacy in our schools? Why are there different graduation rates? Why are there disparities? And so the idea of the data walk is you're hearing from your neighbors, some of the 30,000, or even a larger subset of folks who can dive into and understand data, but it also requires collaboration. So it's not just like at the end of the day, everybody says, oh, here's some interesting data that we learned about together, but there's action that follows afterwards. It really did change the idea of who owned both the issue and the problem. And it wasn't one entity, it was the collective. Those groups that, not just the organizations that convened the data walk together, but those who participated. So if I recall correctly, they had folks from law enforcement saying, can we use those posters? And we're going to do a data walk. And from the school system saying, we want to do that with our teachers. And so they used the data walk maybe as a catalyst for those conversations, but it also brought people together to work collectively on issues. Afterwards, through the Pathways to a Healthy Kansas project, a project we work on that's funded by Blue Cross Blue Shield of Kansas, the leaders in Cowley County were trained in health in all policies, which is definitely a capital H health approach to thinking about policy. And so you think about that. Scarcity is there's not enough, or my group or my issue needs all of the attention or the resources. And leadership or collective leadership is we can do this together, and we're only going to make change if we do work together. And it's a wonderful example, just great leadership in the community, but it also elevated people who I don't think had been identified as leaders before.
Yeah, it sounds like they were empowered.
Yeah,
to learn about it, what their portion of their.
Yeah.
So I just want to lift something up about that real quick, and then I know, Susan, you always have our closing question that you want to leave us with here in just a moment. But that data walk, which is a little bit of a wonky term, data walk, but it was really cool. And it's another example. You're giving us a lot of good examples today, Kari, of things that the 30,000 can do. So you told the story of Mayor Reardon and the unified government and how he brought people together to focus attention. That data walk in Cowley County was similar. It was people at the Community Foundation who said, you know what, we should create a different conversation. And then the police department wanted to do the same thing, and so many different groups in the 30,000. And what it makes me think about is when the problem is what we call technical, the job of the 30,000 is to just solve it.
Right.
Just allocate the resources, solve it, make the decision, solve it. When the problem is adaptive, and the health slide is an adaptive challenge, and climbing the health rankings is an adaptive challenge, being at 29th is an adaptive challenge. When the challenge is adaptive, the role of the 30,000 is to frame the conversation, force the conversation, focus the conversation, and trust people to emerge with the right answers.
Yeah.
All right. Great having you with us, Kari. Susan,
thank you.
how do you want to take us out of here?
Well, I just want to say one more thing about the data walk. What really came up for me as you're describing it is it created a safe space for people to build trust around the problem and learn what everybody's role around that problem was. And, that's a great way to start, right? Around this adaptive challenge. So thank you for sharing that. All right. So this is a time when we talk about our takeaways. So I'm going to go first, and then I'm going to ask you, Kari, next, and then Ed will close us off. Now, so one takeaway for me during this conversation is regarding the collective nature of our challenge. That shouldn't be a surprise. I mean, this is what you learned based on the listening tour that you did of Kansans, right? That's super important. So to the listeners out there, I invite you to think of a situation around health, that's capital H health, and figure out what could be achieved if you collaborated across differences. So that could be different stakeholders, different beliefs, different geography even, right? Just to name a few. So think a little bit creatively about that, what that might look like. Kari, would you like to share?
Yeah, you bet. Ed, you reacted to the term reimagining, and that sort of struck me in our entire conversation and the conversation you and Susan were having earlier too. I guess I would challenge folks who are listening or who are reading the book to think about what they could reimagine too, if they're not limited by what is, and they could envision what we want. That's motivating, and that's the driving force behind leading health and for Kansas to lead the nation in health. It will require reimagining. But Ed, I loved your point. It doesn't have to be only reimagining big picture. It could be reimagining in your workplace. It could be reimagining in your sphere of influence, whatever that is. So challenge folks to think differently and remove those barriers and then work together collaboratively to make it happen.
I love that.
I think for me, my call to action, it's the same, Kari. It's around reimagining, and I love it. And so my call to action would be to ask listeners, what could you ask people to reimagine? You know, the Kansas Health Institute could ask people to reimagine the whole health system because of your stature, your credibility on that question of the whole health system. But for the listeners, what could you ask people to reimagine related to capital H health? It might be how your team supports each other's well-being, your team at work. It might be how your family emphasizes health. It might be how your community focuses on uncomfortable data. But what could you help people reimagine? Thank you for joining us, Kari. For the listeners, the viewers, thank you for joining us. Next time, we're going to be diving into Chapter 5, which is describing Kansas when it's going to be number 1. So if this chapter was looking at the glass half empty, next time we're diving into the glass half full. It'll be great to continue the conversation. Kari, thanks again. Susan, we'll see you next time. Thanks, everybody.
Thanks for listening today. Before we leave, there are a couple ways you can help. The first, visit kansashealth.org/leadinghealth to claim your copy of the book and join in the efforts as we work together to make Kansas the healthiest state in the nation. The second is to share this podcast with your network. Also, we'd love to hear from you. Drop a comment from whatever platform you use to get your podcast.